Thank you for your introduction. Good morning. My name is Osman again, and it's my pleasure to present this presentation as the result of a year-long collaboration that I'm grateful to have been a part of for the last year. And I'm presenting more updated data than that of our abstract, which is included in your materials. I do not have anything to declare. So our study had two main focuses in mind. Number one, last year, the cost of 30-day readmissions in the US was reported by the National Quality Forum to be in the range of $25 to $45 billion annually. And number two, the pay-for-performance paradigm shift has a key focus to reduce not only unnecessary readmissions, but also all unnecessary admissions. But it is even more difficult to reduce all unnecessary hospital admissions due to intensive clinical care needs outside of the hospital. There is no integration with healthcare at the patient's home. Communication, testing, labs, and medication adjustments are not coordinated until the patient is followed up, number one, at the clinic, or number two, they get readmitted within 30 days. And although telemedicine has been proposed as a new approach to reduce hospital readmissions, the current technology and clinical support are insufficient to provide long-term care for these high-risk populations. Our goal then is to use a new approach at the intersection of telemedicine and conventional care, as well as to reduce all unnecessary readmissions as well as admissions. Our clinical model begins with conventional care at the hospital and clinic. We next integrate on-site care using mid-level providers and testing, using labs, vitals, and imaging at the patient's home. And additionally, online care is used for 24/7 monitoring of high-risk patients. And specialty intervention and follow-up is done via telemedicine. We name this model interreality care since it provides both on-site physical care at the hospital, office, and home, coupled with remote virtual care, which is telemedicine over the internet. The study is in collaboration with the Memorial Healthcare System in South Florida. It's the 5th largest public hospital system in the US. And our current extended study includes 109 patients over 20 months. We followed a high-risk cohort, and they had an average of 5.2 admissions or readmissions from CHF, COPD, or infection over these 20 months. We counted admissions within 30 days of an interreality care service date as our own costs. Our results show that the interreality care service model produced an 83% decrease in admission count over these 20 months. And using estimates of inpatient and ICU cost per day from the Kaiser Family Foundation and Dosta et al., we saved $6 million from this reduction in hospitalizations. In conclusion, to our knowledge, this is the first study to test the ability of the interreality care model to reduce both unnecessary hospital readmissions and admissions. The preliminary results demonstrate that interreality care with integrated hospital, clinic, on-site, and online care for patients at home can improve both quality and the cost of care, not only for 30-day readmissions, but for all healthcare admissions. Further study is warranted to examine implementation and scalability of this new model in a variety of healthcare settings, such as ACO, HMO, and public health worldwide. Thank you for your attention. I just entered medical school, and I'm excited to integrate digital health into my future training and practice.